Welcome to this ECG Masterclass. In the next few minutes, we will move from the fundamentals of the electrocardiogram to the interpretation of complex abnormalities. You will learn how to recognize normal waveforms, measure segments and intervals, determine the QRS axis, calculate heart rate, and identify rate, rhythm, and conduction disorders with confidence. The electrocardiogram or ECG is a graphical representation of the heart's electrical activity over time. It is recorded by placing electrodes on the skin which detect voltage changes as the myocardium depolarizes and repolarizes. The standard 12 lead ECG includes 6 limb leads and 6 precordial leads, providing multiple perspectives of the same cardiac event. This information is invaluable for diagnosing arrhythmias, conduction defects, myocardial ischemia, chamber enlargement, electrolyte disturbances, and drug effects. ECG recordings are produced on standardized graph paper moving at a speed of 25 mm per second. Each small square represents 0.04 seconds horizontally and 0.1 millivolts vertically. Each large square represents 0.20 seconds. The calibration mark, a 10 mm square wave, confirms the machine is correctly standardized. The heart's conduction system begins with the sinoatrial node, the primary pacemaker. Impulses travel across the atria to the atrioventricular node, where conduction slows briefly to allow ventricular filling. The signal then moves rapidly through the His-Purkinje system, activating the ventricles in a coordinated contraction. Understanding this sequence is essential for interpreting deviations on the ECG. The ECG consists of 5 primary waveforms. The P wave represents atrial depolarization. The QRS complex represents ventricular depolarization and normally measured less than 0.11 seconds. The ST segment represents early ventricular repolarization and should be isoelectric. The T wave represents ventricular repolarization. The U wave, when present, is associated with late repolarization and may be prominent in hypokalemia. Key measurements include the PR segment from the end of the P wave to the start of the QRS complex, reflecting AV nodal conduction delay. The ST segment from the end of the QRS to the beginning of the T wave. The PR interval normally between 0.12 and 0.20 seconds. The QRS duration less than or equal to 0.10 to 0.11 seconds. The QT interval corrected for heart rate typically less than 440 milliseconds in men and 460 milliseconds in women. The QRS axis indicates the general direction of ventricular depolarization. Using the quadrant method, if lead 1 and AVF are both positive, the axis is normal. Lead 1 positive and AVF negative indicates left axis deviation. Lead 1 negative and AVF positive indicates right axis deviation. Both negative indicates an extreme axis deviation. Heart rate can be determined by the large box method, 300 divided by the number of large squares between R waves. The small box method, 1500 divided by the number of small squares between R waves. The 6-second method, count the R waves in 6 seconds and multiply by 10, preferred for irregular rhythms. Bradycardia is defined as a heart rate below 60 beats per minute. Tachycardia is defined as a heart rate above 100 beats per minute. Both can be physiological or pathological depending on the context. Common rhythm disturbances include sinus arrhythmia, variation with respiration, atrial fibrillation, absence of P wave and irregular RR intervals, atrial flutter, sawtooth flutter waves, ventricular tachycardia, wide QRS complexes with regular rhythm, ventricular fibrillation, chaotic baseline with no organized QRS complexes. First degree AV block has a prolonged PR interval. Second degree Mobitz type 1 or Wenke back has progressive PR lengthening until a beat is dropped. Second degree Mobitz type 2 has dropped beats without PR change. Third degree AV block has complete dissociation between atria and ventricles. Right bundle branch block has an RSR prime pattern in V1 with a QRS over 0.12 seconds. Left bundle branch block has a broad monophasic R wave in V6 and absent Q waves in lateral leads. ST elevation may indicate acute myocardial infarction, pericarditis, or early repolarization. ST depression suggests myocardial ischemia or reciprocal change. T-wave inversion may reflect ischemia or ventricular strain. Tall, peaked T waves are characteristic of hyperkalemia. A systematic ECG approach includes 1. Verify calibration and speed, 2. Determine rate, 3. Assess rhythm, 4. Evaluate P wave and PR interval, 5. Measure QRS duration and axis, 6. Review ST segments and T waves, 7. Check U waves and QT interval, 8. Correlate findings with clinical presentation. While ECG is traditionally associated with cardiology, it plays an important role in physiotherapy for patient assessment, monitoring, and safety, particularly in patients with cardiovascular or pulmonary compromise. Establish a patient's resting heart rhythm, rate, and any conduction abnormalities before beginning physiotherapy interventions, which can help to identify underlying cardiac risks that may influence exercise prescription or respiratory care, specifically patients of arrhythmias or previous myocardial infarction. In cardiac rehabilitation, ECG monitoring ensures the exercise intensity stays within safe limits. It detects signs of myocardial ischemia early, preventing adverse events. In pulmonary rehabilitation, ECG helps track cardiac responses to exercise and prevent overloading compromised cardiopulmonary systems. Continuous ECG helps identify arrhythmias or cardiac strain during weaning trials in the ICUs. Also, during post-surgical rehabilitation, especially after a cardiac or thoracic surgery, ECG ensures mobilization is safe. Physiotherapists working in sports or rehabilitation may use ECG monitoring to detect abnormal heart rhythms triggered by physical activity, guiding modification of training or rehab programs. Some breathing or airway clearance techniques affect intrathoracic pressure and heart rate. ECG monitoring helps confirm patient safety in high-risk individuals. Physiotherapists can explain ECG findings in simple terms to improve patient understanding of their cardiac health and promote adherence to safe exercise guidelines. Thank you for joining this ECG Masterclass. For more clinical training resources, subscribe to the channel and activate notifications. Share this video with colleagues and leave your questions in comments.